You look so great.
Thanks.
All right, we'll just jump right into it. So hi, everyone. This is Nina Collins. I'm here from Revel, the events and community platform for women over 40. Today, we are interviewing Dr. Suzanne Steinbaum to talk about women and heart health. Suzanne is a complete pro. She's like on all the best of doctor lists. She's worked at all the best hospitals in New York. She runs a practice. She's written a book on women's heart health, which is a great book. Remind me what it's called, Suzanne.
The Heart Book, Every Woman's Guide to a Heart Healthy Life.
And as I was saying to Sydney before you popped on, Suzanne, this is the opposite. I do a monthly call with my old therapist, Debbie Maggots, who I adore, who was my therapist. And now we have like this professional relationship that's super fun. But you're kind of the opposite. I met you through the community and through your book because you're such a talented female cardiologist, and there aren't a lot of female cardiologists. I've learned. Maybe there are more now, but it really is a man's world, is my sense. And so I met Suzanne through work, and then I was getting older and I needed a cardiologist, and so she has now become my cardiologist, thankfully. Sorry about that. So anyway, I'm very glad to have you. Welcome.
Thank you for having me. I love chatting with you. What?
Yeah. Where are you calling in from? Are you at home? Are you at work?
I am at my office. I just ran in from seeing my last patient to hang out with you.
Okay, good. And you're not wearing red. Suzanne often wears red, which is super cute. But I love your black furry thing.
I have to tell you, when I was walking out of the house, I was like, oh my God, I should put on a red scarf. And then I was like, yeah, this black furry thing and a red scarf would be overkill. So
yeah, then you would really look like a drag queen.
I have like my red hearts.
You look amazing. So for our attendees, just so you know, the way this works, it's a webinar and it also gets recorded and sent out as our podcast later in the week. You are very welcome to ask questions in the chat. You're also welcome to raise your hand. As long as you're comfortable being recorded, we won't identify you by last name or anything. So feel free to chime in if you want to ask questions, and I will be monitoring the chat otherwise. So let's just jump in with, women's heart health is something that is not talked about enough. I think it's talked about more now, but not enough. And in menopause, it's not uncommon for our cholesterol to go up, which happened to me. So I guess my first question for you is, what is your sense of the landscape for women's cardiology in middle age, particularly have things gotten better? Is it mostly a man's world?
I would love to sit here and tell you that the 20 years of me talking about this nonstop has made an impact. But what I'm going to tell you is a little different than that, unfortunately. There's actually been shown to be an increased incidence in the risk of heart disease and stroke in women less than 55. And when we think about it, it's just insane for me mentally, because when I started, there was literally no such thing as women in heart disease. We didn't learn about it. We were told women don't get heart disease. So then the years went on. Yes. And in fact, I tell this story all the time. I was in the emergency room. I was in my training, told women didn't get heart disease. There was like a 54-year-old woman wheeled into the ER, holding her chest, nauseous, throwing up, sweating, and she was put in the corner with the diagnosis of gastroenteritis and had a heart attack in the emergency room. Jesus. And I was blown away. That aha moment, stopped, looked around, are you all seeing this? Women are getting heart disease and having heart attacks. And literally, I was told there's no such thing as women in heart disease.
Why? Why would they think only men get heart attacks?
I'm going to tell you, it is really the logistics behind the research. So the 20 years prior to 1986, so more women started dying of heart disease than men in 1984. The 20 years prior to that, all the research was done on men. So they just assumed it was a man's disease. It all caught up to women in 1984, and all of a sudden women are dying of heart disease more than men, and in fact, more than all cancers combined. Then it wasn't until 1993, which like in research language is yesterday, that the Office of Women's Health was opened in the NIH, and now women became part of trials.
Wow, so in 1993.
1993.
Wow.
So all of a sudden, we're getting more and more information about women's hearts. Go Red for Women started 18 years ago. I've been a spokesperson for them from the beginning, but it's only been 18 years that this message has gone out there. So what happens without awareness, without education, without the research, and with the doctor's bias, not looking for heart disease in women?
Right.
More women are still dying of heart disease, and women less than 55, there's a greater incidence.
So why is there a greater incidence? First of all, like, why is that happening more now?
So, I used to joke around, when you look at 1984, what happened, like more women entered the workforce equal to men. And like, okay, we wanted that glass ceiling shattered. We got their disease too.
Oh, I see. So more stress.
Well, let's look at that, because it's not only the more stress, because I do think women have more stress. We have more stress than men because we do everything. The men just kind of, listen, I'm obviously giving a sociology understanding of most women,
Oh,
not
yeah.
all women,
Yeah.
but most women are taking care of their families, taking care of the home, taking care of their jobs. And one of the things that COVID shed light on is the reality of this, that this is in fact most women's lives. And if we talk about stress and what is going to happen to women since COVID, which I'd like to talk about for a moment, part of it is stress, but part of it is also lifestyle. So what happened to these women? Many of them became overweight. Many of them became diabetic. What happens when these two things happen? Cholesterol goes up, blood pressure goes up. And all of a sudden, you have a population that was usually considered really healthy and vital, having these risk factors of heart disease earlier and earlier from lifestyle and from really what's been going on. When I look at COVID, there was a 29-pound on average weight gain during COVID.
Yeah.
There was an average of blood pressures going up in about, I think it was 18% of people. Now, look at what happened to the women who either lost their jobs or were carrying their
Take
jobs.
care of all those kids, right? All that caretaking during COVID and
All
jobs.
of that.
Yeah.
I guarantee in 5 years from now, all of those women that have been suffering, and we're still suffering, are going to have an increase in heart disease. That's kind of how it goes.
So it's really lifestyle, which of course makes sense. And actually, you haven't seen me, but I've lost 15 pounds since May, and my cholesterol has gone down, right? We had a telemed visit a couple months ago. So yeah, I mean, I, like everyone, gained weight during COVID, and my cholesterol was steadily going up in the last few years. So let's talk about, when should women start really worrying about their heart health? Like, no one told me to see a cardiologist. I only did one because I had spoken to you and kind of started to be aware of what an issue this is. And I have a history of heart disease in my mother's side of the family. And I have an aunt who had a terrible stroke at 74 and is in, not speaking, in a rehab facility for the last 5 years. And that's not something I want to happen to me. So I became aware of all these things and decided to proactively see you. For your average woman, what is your advice? Like, when should we start getting specialized cardiac care?
So here's the deal. 80% of the time, heart disease is preventable, and it's based on the risk factors. These risk factors are high blood pressure, high cholesterol, elevated sugars, being overweight or obese, sedentary lifestyle, poor diet, and also stress, anxiety, depression, and certainly the family history. Every woman should first be checked at age 20. But based on your risk factors and based on your family history, depends on how often you should get checked thereafter. You just mentioned a weight gain. You mentioned your cholesterol going up during that time. Now, let's face it, perimenopause is one of these times that our bodies start changing.
Yeah, why is that? Why does our cholesterol often go up with perimenopause?
As estrogen decreases, all of our protective happiness goes away. And so we have an increase in cholesterol and an increase in blood pressures. And that really happens with the shift in hormones.
Mhm.
So depending on what stage you are in life, and let's talk about it, 20s, we're fine, we're healthy, we're good. Okay, are we going to start having babies? When is that going to happen? Is it 20s, 30s, even 40s? If we have any problems with pregnancy, like high blood pressure or preeclampsia or elevated sugars or gestational diabetes, guess what? We are at risk for heart disease. So if any of those things happening, you need to really start going to a cardiologist. So in your 30s, 40s, depending on what happens, if there's weight gain, if there's perimenopause, if there's a family history, you're going to want to go more often because it takes decades for these risk factors to lead to heart disease. And there's
Right. And if you get on it early, you can really start to prevent certain things. And it makes me really frustrated that, like, my primary care doctors, I really feel, I mean, the whole thing about how doctors don't talk about perimenopause is so true. And when you're 42, 44, your primary care doctor should say to you, like, these things are going to start to happen, and these are the ways you might want to proactively deal with it. No one says that to you. It's very rare.
I'm going to tell you that when you look at the studies, the most primary care doctors are not aware of how to deal with heart disease in women. They're just not. And there is this notion that they'll talk about weight, right?
Right, but they don't even really link it to anything. I mean, they
That's
don't
right.
say, yeah, because I
say,
really noticed this fall when I lost 10 or 15 pounds, it really affected my cholesterol.
Right. And they don't say, I care about your weight, not because of what you look like, but
Right.
because it deals with heart disease. And there are studies on this. This is not like you're just experiencing it. We're looking at statistically how many doctors don't know about prevention, don't know about women and heart disease, and don't even know how to communicate with their patients about it.
Well, so that alone is reason to see a cardiologist. I think it's very hard to find a female cardiologist, though, a good one, because I had a boyfriend at one point who had a heart disease issue. He actually died of a heart attack. But he was looking for a surgeon, and they were all men. Like, they were just all men.
Yeah. So 18% of cardiologists in the country are women.
18. Okay.
When you look at 2002, 18% of cardiologists were all women. 20 years later, no difference.
Wow.
It's shocking.
Yeah, I remember when I worked at a hospital for a few years, Maimonides in Brooklyn, the whole cardiac team, they were all men. They were just all men.
Yeah.
So I would recommend to our listeners that you try and find a female doctor, because I would think a female cardiologist is going to be much savvier about these issues, given how much they're kind of ignored and not really dealt with. Tell us about statins. Why would someone take a statin? Are they safe? What's your feeling about statins?
So let's just jump right in. Statins are not as horrendous as people might read if they go online or in. There's so much bad.
I've heard some people say they're great and they're like really life-saving. Like, I don't really understand the controversy around statins.
There's not really controversy. Some people have side effects just like every other medication. I will tell you one of the controversies, and let's start with that and then I'll go backwards. There were new guidelines that came out about cholesterol. And those new guidelines were about 4 years ago. And basically, they re-risk stratified people. And what I mean by that is by putting in patients in high risk, moderate risk, or low risk for heart disease. And it was determined based on these new guidelines that these patients who need to be on statins because of their risk, the risk stratification increased the number of people on statins by 11 million people. And so people who look at things like that, they go, this is the pharmaceutical industry.
Yeah, I was about to say that's really good for the pharmaceutical industry.
Right. So that's the downside. And then, you get a little suspicious and all the other things. Let me tell you something about statins. They are probably one of the most life-saving medications we have out there. They don't work just to lower cholesterol. They work to decrease inflammation. I think a lot of us have heard the bad stuff about inflammation, and statins do stabilize plaque and decrease inflammation. But we determine who needs to go on a statin right now based on your 10-year risk of heart disease. And that's looking at those risk factors. And it's also looking at some screening tests, like something called a coronary artery calcium score.
I was going to ask which tests women should have, say, like in their 50s or 60s, or I don't know when, but what are the tests we really should be having?
So that's one of them. It's a calcium score, which is a CAT scan, no dye or contrast, and it picks up the calcium in the arteries. If you have calcium in the arteries, that means you have plaque, and statins are a great, important part of your life at that point. There was some controversy. Are they good for women? Are they not good for women? And I will tell you, yes, they're great for women, but they're not great for every single woman. It's this whole idea about aspirin. Some information came out recently, don't take aspirin. Well, that's not true, but it's not right for everybody. And this is why having a doctor is important.
Yeah. So who shouldn't take statins and who shouldn't take aspirin? Like, are there rules about that?
Well, there are some rules, but it really, again, goes back to this 10-year risk. It goes back to all your risk factors, and it goes back to determining the risk and benefit of being on the medication. So, for example, if you're a 25-year-old woman and your LDL cholesterol is borderline, but you're a marathon runner and everything else is great and you're fine, let's hold off on taking a statin. But if you have a strong family history, your cholesterol's high, you have high sugars, you have high blood pressure, you're not that healthy, and we find out that you have a genetic marker for heart disease and the calcium score is 100, yes, you take a statin.
Yeah.
But there is actually a calculated risk analysis that many doctors have on their phones, that really you can determine your risk and whether or not you're a candidate. I'm going to give you my bias, if I may, for a moment.
Yeah, please.
And this is my perspective. I'm not a huge fan of this risk analysis because it actually only stratifies women into high risk if they're over the age of 65 or they have multiple severe risk factors. My career right now has been focused on really coming up with the risk analysis that is important and specific for women. So I think it depends on the individual, and having the conversation with your doctor about it, for me, is more relevant than actually calculating it by that, because it misses women and it bothers me.
No, and for context for our listeners, I went on statins under Suzanne's care, but I'm on a very low dose of Crestor, and I think I only take it three times a week. My cholesterol has gone way down. So with the weight loss and the Crestor, it seems to be going in the right direction. And I really wasn't sure whether to take it because I'm not obviously super high risk, but I have some of the risk factors, and I just made the decision ultimately with Suzanne to do it. So it's you're right, you have to really talk to someone really good to figure it out because it's a nuanced conversation, and
That's
it's kind of
right.
like HRT. There's no one size fits all. The test again, the calcium score test, what's it called?
Coronary artery calcium score.
Okay, coronary artery calcium. Coronary artery calcium.
You want me to write it?
No, it's okay. I can write it. And what other tests should people definitely have, and how often? Like, what about a stress test? What about the Boston Heart test? Maybe you could talk a little bit about the Boston Heart test, which you did with me, which I found fascinating.
Yes. So let's just talk about that for a second, because I'm a preventive cardiologist and my study has been on less about disease and more about how to prevent the disease. So I look at things from a cellular level, and I look at things from the level of what's called the endothelium, which is the lining of the artery. Now, I always say everyone's talking about heart disease, and I'm literally talking about the endothelium, but it doesn't sound so sexy, so I don't know. But the lining of the artery is what protects our arteries from the development of plaque. And if we keep that lining healthy, we don't get plaque in the arteries. So how do we keep that lining healthy? It's diet and exercise and stress management and keeping all those risk factors down. So I don't do just the standard cholesterol panel that most doctors do. It looks at cholesterol and triglycerides and LDL, the bad stuff, and HDL, the good stuff. And that's kind of it. But what I really look at are how many of those particles are dense and small. There's something called apolipoprotein B, which is a much more sensitive marker for really having LDL that leads to plaque formation. It looks at things called lipoprotein a, which is a genetic marker that is so significant for the development of heart disease, especially in young people. The very sad thing is this is not part of a panel yet that most doctors do.
The Boston Heart Test, right?
Boston Heart Lab.
Boston Heart Lab.
And also this lipoprotein little a.
Lipoprotein little a. Okay. I'm writing these in the chat and just repeating them for people who will be listening. Yeah, because the Boston Heart Lab test was super interesting and it wasn't that expensive, if I recall. Like it seemed kind of like a fancy, weird test. It takes a while to get the results. Insurance probably doesn't cover all of these things, I would imagine, right?
Most insurances don't, and it depends on the doctor that you see. I've been working with them for a very, very long time. And the tests that I do, every single test I do has a reason behind it. You can draw pages of blood work, but unless there's something that it means that we can act upon that is so relevant to who you are, again, everything is tailored to you. There's not a one size fits all for prevention. And I think that's part of the issue. But getting these tests, you start early, and depending on who you are, you get it once a year.
Yeah. All right. Well, so, I mean, this does make me think about access. This is a conversation that makes me feel a little frustrated about health, health insurance in the state in our nation of access, because it's one thing to find, it's hard enough to find a good primary care doctor, but to find a good female cardiologist is probably really hard. Can you give us some tips for our listeners on how to find that doctor?
I would like to say, and I got to say this because I've been spending the last 20 years and certainly now the last two launching a platform, a software platform with my program on it that is going out nationally to physicians all over the country. And it's launching in January. It's called Cadence. And so I would love everyone to stay on track with Cadence Heart is the platform. And on Cadence Heart, I will be having educational videos. We're having sort of what you're doing, bringing people together. And we're also bringing doctors on board so they can deliver prevention across the country the way that I'm delivering it in my office. That's right amazing. Now, access, I would say the American Heart Association is a great website. You can look up physicians on there. If you live in an area with an academic hospital, you can look up. Many academic hospitals have women in heart disease programs. I would suggest that you try that as well. Those programs are more tailored for women, and they are throughout the country at academic hospitals. It doesn't necessarily mean they're prevention and doing all the stuff that we're talking about today, but they are more likely to
at least know about this Boston Heart Lab test, for example.
And calcium scores and things like that.
Okay. And what do you think of red yeast, yeast rice as a statin alternative, by the way? One of our listeners says it's worked well for her along with 369 omega oil. And yeah, I've been taking omega too, but I remember looking up red yeast and felt like it was a little controversial. What's your sense of it?
So red yeast rice has the same biochemistry that a statin has, but it's the same as one of the early statins. That's a very weak statin. So it works. It can bring down your cholesterol. It's not FDA approved, so you never know exactly what you're getting. There's some more reputable companies that make red yeast rice. I would go for those. But to the point of what you mentioned about your own statin, we have you on a very low dose 3 days a week because it's very potent, it's very powerful, and we don't need to take that much.
Right.
It depends on the person, how much red yeast rice you might need. And so that's what gets a little complicated because it's not very strong.
Yeah, I mean, I was scared to go on statins, and I have to say I haven't felt a thing. Like I don't have it. I mean, I'm just lucky. There have been no side effects, and it seems to be helping. And I feel like I'm probably doing something that's probably smart for me. But again, it's different for everyone. A listener is asking, can you tell us about BNP blood test and interpreting the results? What is a BNP blood test?
So proBNP is a marker that's released in the body when there's pressure on the heart in the setting of heart failure. So in people who have a decrease in heart function and their heart isn't pumping blood out as well as it should, there's actually a lot of pressure in the heart and backflow of fluid that goes into the lungs, and it's associated with shortness of breath, swelling, a lot of different things like that. And proBNP can help make the diagnosis of heart failure.
Okay, good to know. Do you need to monitor liver enzymes with a statin? Oh, now I'm getting nervous.
We always monitor your enzymes.
Oh,
Yeah.
you
And
do?
I always,
Okay.
yes. And I always check them once we are on a statin and we have a stable dose. You don't have to check it as often, but remember in the beginning, we were seeing each other more often. I
Mhm.
do want to mention that the studies of statin were done, guess on whom? Men. And so the doses for women are the same doses that they give to men. We metabolize differently than men. And that's why a lot of women have side effects on statins because they're given too high of a dose. I never dose the same in my women patients, just to
Oh,
let you know.
that's really interesting. So what about the stress test? I know you have me coming in January for another one, and I did one, I guess, a little less than a year ago. How often should people be having them and why? What does the stress test tell you?
So this gets again to the difference between the stress test that I do and that most doctors do. We do something called a cardiopulmonary exercise test, and that actually can diagnose the health of that endothelium, the lining of your artery. We get to test something called your Vo2 Max, which is one of the most sensitive markers of your cardiovascular vitality and fitness. The American Heart Association actually called it the most important vital sign. Yet, it's not used as standard of care as a stress test. So the stress test that I do is really a deep dive into your metabolism and really into your physiology, and really tells me how physically fit you are and how we can get you to a better place. The stress test that most doctors do is a treadmill stress test. It only picks up disease if the blockages in the arteries are 70% or greater. And so it's not necessary for someone running around like you who's exercising, fit, vital, and fabulous. That test is probably going to be normal. So the test that I do is just really sensitive and really specific for women's hearts.
Got it. Interesting. A listener is saying that if I putting the names of the tests in the chat, she's not seeing them. I think that happens when you join later, then you can't see what's in the chat already. What I'll do is save the chat and I'll email it to everyone at the end. I'll email it to all of the attendees at the end. VDO Max, someone's asking for this VDO. What was the name of it again?
Vo2 Max, that's minute ventilation.
There are a lot of, I do have to say, I do find it confusing, and I'm sure our listeners are finding it confusing. Like when I was going through this exploration with you last year about my cholesterol, and it's a lot of, and you do a great job of trying to explain it, but it's obviously very complicated stuff. I mean, there are a lot of different tests. You did a marker for me. What was it? The one that shows a little bit of a propensity for Alzheimer's?
Yes, ApoE.
That's ApoE, right? You talked about that earlier. But
And
again, it seems like similar to heart prevention. I remember once actually doing a panel with you, and you had that great guy who's working in Alzheimer's prevention. And a lot of
yeah,
the stuff for Alzheimer's prevention is very similar to the advice for heart disease prevention, right? It's pretty
right.
basic. It's diet and exercise and stress and
So I would love to talk about ApoE. It's a little different than the one I mentioned earlier. The one I talked about earlier was apolipoprotein B, which carries LDL. ApoE is actually a genetic marker that tells us how well we process fats. And if you have an ApoE of 3,4 or 4,4, it actually predisposes you to heart disease and Alzheimer's. And the reason is the body can't get rid of the fats in the bloodstream, and those fats kind of sit there and they lead to plaque. And so, to your point, I brought this preventive neurologist on to talk about ApoE. Well, guess what? If you have an ApoE and you go on a mostly vegetarian diet or a Mediterranean diet only with good fats, you are actually going to decrease your risk of heart disease and Alzheimer's simply by changing your diet.
Mhm.
So these are markers and tests that are so powerful in prevention. And again, these are tests that every woman, I think, should have. I think it's a shame that it's not part of it needs to be part of the panel. And if you start doing the research and looking out there, you'll see these things exist. Unfortunately, it takes about 50 to 20 years for our research to hit our guidelines. And that's why we're not quite there yet.
Okay, so I think the two takeaways from here are, I'm going to ask you one more time to repeat the tests that you think are really important. And then I would say the other thing is, we all know that eating well and a good diet and losing weight is good for us, but we don't, it's true that I think particularly for women, there's so much shame around bodies and fat. And so I think we tend to not really hear it all the time, that it's just about our health. Like, it's not about the way we look, but it's about our health. And if you
Yeah.
can kind of digest that and start eating better, digest that, so to speak, it really can make a huge, huge difference. So let's hear the list of tests one more time, if you don't mind. Then we're going to answer one more question, and then we're going to let Suzanne go back to her busy day.
So I think it's important everyone do get a cholesterol panel. The advanced tests that I mentioned are lipoprotein little a, which is a genetic marker associated with heart disease. The other one is ApoE, and the other one is apolipoprotein B. Those are all markers that can really help us understand not only our risk, but there's something that we can do about them, like the ApoE, by changing our diet. An EKG and an echocardiogram are also two tests that I would suggest could be important for a woman, especially with symptoms. So palpitations, shortness of breath, chest pain, an echocardiogram would be recommended. And the other is a stress test that usually is not done until there are symptoms. And when symptoms exist, even if it's fatigue, difficulty exercising, change in exercise, things like that, I personally recommend a cardiopulmonary exercise test. It's more sensitive, it's more specific, especially for women. And then the screening test, which is the coronary artery calcium score we talked about, the CAT scan without dye or without contrast, that looks for calcium in the arteries.
Yeah. And the Boston Heart panel we talked about, which is another specialized test. I mean, this is, so to Trisha's question, do we need to be suffering from a problem before we see a cardiologist? No.
Oh,
You want to, the idea is prevention. So you want to be thinking about what your risk factors are, your family history, your stress, your blood pressure, your sugar levels. When you're younger, I mean, I think the best advice is probably to start thinking about this stuff in your 40s at least, right? I mean, Suzanne said someone should first see someone when she's 20. Look at these. I mean, I have a daughter who has very, very high cholesterol and is also in Suzanne's care. And she's only in her 20s. So
I think it starts at 20. And
yeah,
then as you get older, you just go more often,
yeah,
because
yeah.
things change.
And to Trisha's question, does insurance cover these? A lot of times they don't, and it's super fucked up.
Yeah.
It's really bad. It's a problem with our system, and it's incredibly sad, but it's a question of privilege often.
I have to tell you, the only one that I know for sure is never going to be covered is the coronary artery calcium score.
Why is that?
I don't know. And you know what's crazy about it? It's been part of the guidelines. It is actually recommended by the American College of Cardiology and American Heart Association as part of the guidelines.
And it was so easy to do. I remember when I did it, it took like
15 seconds.
It was nothing. Yeah. How can that cost money? It's so infuriating. The healthcare system is so bad.
I think Texas covers it now. I think they're the only state that covers it. But you've got to see, it depends on the state. But the test itself is about $100 to $150. If you look for it and it costs any more than that, don't get it done. They're ripping you off. Don't do it.
All right. This is really great. And I will say to everyone, if you didn't catch any of these names, this is obviously being recorded. So you can watch this again. You can listen to it on our podcast. You can write everything down. We're going to do one last question. What if you've had calcium in your iliac vein at one time? Would insurance now cover some of these tests several years later? It depends on your insurance, I would guess.
I'm not sure about your diagnosis. So did you have a clot or did you have calcium? So that's different. And based on exactly what you had a stent. Ah, I see. Mm-hmm. All right. So yes, you have a diagnosable disease and all of these tests will be covered.
Okay. So that's good news. Is there any research into medications that will lower LPA? What's LPA?
That's LP little a. That's how you write it in medical language. There has been tons of research into medications that lower this marker. There is one medication that does, it's an injectable, but all the research shows that if you have an elevation in the LP little a, getting the LDL 50 to 70 and as low as possible is the most important thing. If you have a lot of calcium, if you have a very high cholesterol, then one of the new injectable medications does decrease LP little a and does decrease your LDL, and that would be recommended for you.
This is so great. You know so much. I mean, Suzanne, it's awe-inspiring. You're amazing. I'm going to say one more time, Suzanne has a great book called The Heart Book.
The Heart Book, Every Woman's Guide to a
Every
Heart
Woman's
Healthy Life.
Guide. So I strongly suggest you check that out. You should also definitely look up Suzanne's website. So she's Dr. Suzanne Steinbaum. She's in New York City. The new project she's working on is called Cadence, right? Cadence Health.
Yeah.
Cadence Heart. Cadence Heart.
We'll be launching in January. So just go on my website and you can track it.
Okay, you can track it. You can always write to me if you have questions or if you want to be put in touch with her. And yeah,
Nina,
thank you all for listening.
I hope to everyone out there, Nina's is inspiring you because she's not only having this conversation, but she's sharing with you her story. And you can tell through her story, you don't need to get sick. You don't need to get heart disease. And you can actually do this in a way that's not scary, no side effects, feeling healthy, living a vital, fabulous life. And it is all possible. So thank you for being the poster child for everyone.
Oh, and the last thing I want to say thank you is that one of the last times I saw Suzanne, I went into her office and she was eating a salad. And it also just did remind me that the value of just eating well is everything, everything.
Yeah.
You know, and that's something that doesn't cost us money. And that's not something that insurance can screw us around over. So I encourage everyone to eat more salad. Suzanne, love you. You're fantastic. And I will see you in January for my checkup. And thank you to everyone.
Thanks for having me. Take care.
Bye, guys.
Bye.